Good afternoon. Welcome to UCSF Medical Grand Rounds. I'm Bob Wachter, Chair of the Department of Medicine. The usual ground rules today. Closed captioning is available. If you have questions, please type in the Q&A box, and we'll try to get to as many as we can at the end of the talk. If you're interested in CME, stay on at the end, and there'll be an address as well as a barcode that will take you to the right place. And as always, we will post this on YouTube in a couple of days and for later viewing. Today, I think will be an incredibly interesting and timely talk. And I have to say, whenever the topic of screening colonoscopy comes up, I always point people to an essay by the humorist Dave Barry on his own colonoscopy. It was written in 2008 and was published in the Miami Herald. And I will regale you with one paragraph of it. I think it captures something that it's sort of a universal experience, but I think captures it beautifully. Barry writes, "The instructions for movie prep," which is one of the versions of the prep that you take preparing for a colonoscopy. "The instructions for movie prep, clearly written by someone with a great sense of humor, state that after you drink it, quote, a loose watery bowel movement may result. This is kind of like saying that after you jump off your roof, you may experience contact with the ground. You spend several hours pretty much confined to the bathroom, spurting violently. You eliminate everything. And then when you figure you must be totally empty, you have to drink another liter of movie prep, at which point, as far as I can tell, your bowels travel into the future and start eliminating food that you have not yet even eaten." So that sort of captures some of the challenges of colonoscopy, but more seriously, we go through that because we've taken as a given that colonoscopy is a life-saving procedure with a strong evidence base. But a recent study that got a lot of national and international press questioned that assumption, which makes it a terrific time to take a good look at the evidence base and what we really do know about colonoscopy in the context of how we think about screening procedures in general. And we are very fortunate. One of the world's experts on the topic is a close friend of ours and a member of our volunteer faculty, Dr. Doug Corley. So let me introduce Doug. He is Director of Delivery Science and Applied Research at the Permanente Medical Group. He's also Clinical Professor of Medicine at UCSF. He's a cancer epidemiologist and gastroenterologist with an interest in modifiable patient, physician, and health system factors to improve patient outcomes, with a particular focus on GI cancer screening. He's been the principal investigator on 20 federally funded studies related to GI cancers, risk prediction, genetics, etc. He was the National Steering Committee Chair for the NCI's Population-Based Research Optimizing Screening through Personalized Regimens Consortium. And he also just completed a term as editor-in-chief of GI Specialty's leading journal, Gastroenterology. So, Doug, we're thrilled that you are part of us, and we're thrilled to have you here today to talk about controversies and progress in colorectal cancer screening. Welcome aboard.
Great. Well, Bob, thank you so much. Such a pleasure and such a privilege to be able to be with all of you today. I only wish it was in person. I love being able to have the interaction and a lot of that discussion. And I realize that it's hard to be able to replicate with Zoom. I would encourage people to be able to put questions in, and we can have a good discussion around a number of the topics today. If there's something in particular that you want to be able to kind of just stop, I'm happy to be able to go over at that point in time. Feel free just to turn on your microphone and be able to speak up. I don't know if that's kind of the usual protocol, but in addition to what Bob had said in terms of being able to put things into the chat. I'm going to start sharing my screen and let me know if, can you see that okay?
Yep, you're good.
Great. So we're going to be talking about a number of different areas. One of them is the one which Bob had mentioned around this colonoscopy study, but the others are in some ways their own controversies that may even be more substantial and that you probably will be coming into yourself either personally making a decision or for your patients. In almost any field that you're in, whether you're in primary care, gastroenterology, surgery, almost any topic area, this will affect, because colon cancer screening affects everyone who reaches the age of 45. So, we go after obvious targets to decrease colon cancer screening deaths, but what if this doesn't work? This is a study that was done a number of years ago, and these trends have generally continued. But the interesting thing is it lets you be able to see by modeling studies what the general effects are for different things for decreasing colon cancer. So the black line is, the general trend for colon cancer deaths over a very long period of time. But you can see actually that the effects of treatment or risk factor reduction were relatively modest. And this is only through 2005. A lot of the effects were related to screening. But there's still a lot of deaths from colon cancer. And what the question is kind of how can we get lower with, as a society overall? And there's even deaths with effective screening. So it's not just a matter of being able to get people screened. This always is kind of shocking to me in terms of the estimated deaths in 2020 from different causes, just like how many are due to lung cancer. But colorectal cancer is the second leading cause. It's partly because it's present in both men and in women. But if you assume that you have effective tests for decreasing cancer deaths, even if you take that number of deaths and decrease it in half, you still have almost all of the deaths that are happening from lymphoma or kidney cancer. There's a lot of mortality and morbidity, even if you're decreasing the number of colorectal cancer deaths, because there are just so many of them currently. So we'll be going through a few different topic areas. One is, does screening work? The second is, which screening test is best? The third is does surveillance matter? And the last is, does it matter who does my colonoscopy? So let's kind of go through these. First of all is part of the how. Unlike some other cancer screening areas, there's a lot of ways of being able to do colon cancer screening. One of the first ways was with sigmoidoscopy. And then an extension of that now, you might say, is with colonoscopy, where rather than looking part of the way around, you look the whole way around. On the top right is what a FIT test looked like. These can be sent through the mail. You can see there's like a little screw that's on there. You simply put it into the stool sample and you put it into this container, and then it's mailed back or processed. On the bottom left is the box that comes with the Cologuard. People sometimes think of this as the DNA test. It's actually a FIT DNA test. So it has a FIT component, just like a regular FIT test. And then it also looks for certain changes that are suggestive of cancer or neoplastic DNA. And so it has those two tests. Anytime you put two tests together, you're going to have higher sensitivity than either one of those tests by themselves. And you're also going to have more false positives. And so we'll talk about what some of that means for the Cologuard test. It also, as you can see, comes in a box. It's a little bit bigger to be able to ship and to be able to move around. And it has some other kind of interesting aspects to it. And then finally, there are some blood tests, and there's going to be more and more of these which are coming out. The main one, which is approved currently, is called Septin-9. Septin-9 has not really gotten a lot of traction, partly because its sensitivity is relatively low. So, what is the evidence kind of behind these tests? The two main areas that have kind of what we would call the highest quality evidence, are the fecal occult blood tests and sigmoidoscopy. So both of these have randomized trials. And so those are the ones which are kind of like in our top left, highest level of evidence. The next two are both ones that are evidence that's kind of like extension of those, but with pretty strong evidence from cohort and case control studies. So there's the indirect evidence, which is that FIT test is another stool-based test that tests essentially for blood, for hemoglobin, like the FOBT, but it's both more sensitive and more specific, and it doesn't require any dietary changes and other things. Because of this, it's really replaced FOBT. Really no one is using FOBT anymore. The second is colonoscopy. Again, same concept as sigmoidoscopy. If sigmoidoscopy is protective by looking part of the way around, colonoscopy looking the whole way around, should be better. But there had not been any randomized trials of colonoscopy, and there are no direct randomized trials of FIT, although there were of FOBT. And then the last is the FIT DNA. That's also an indirect evidence, but without really large cohort or case control comparative studies. One of the big strengths of it is actually navigation. So that if you are out in a practice that is not kind of mailing things out or have difficulty with tracking, they do more of the navigation of making sure that patient kind of follows up on abnormal tests and getting notified around those. It also is projected to have a lower frequency every 3 years instead of every 1 year, such as fecal immunofit testing. But the challenge with all of these things is, it's a lot of indirect evidence. And if you use it as suggested, the modeling studies would suggest that it's dominated by fit. These are these cost effectiveness analysis. Well, what does dominated mean? Dominated means that compared with annual fit, the estimate is that fit DNA would be both less effective and more costly than fit. So one of the big strengths and is this navigation part. It's advertised heavily because it has a company which is behind it. But if you're saying like, well, what's the best one? This is a little bit of a wild card with it because it gets into this question about convenience, compliance, and kind of what could be done. So as a one-time test, you're doing one fit or one fit DNA or one colonoscopy. That's different than using it as a program overall, like, well, what would happen over 10 years? And we'll talk about that in more detail a little bit further on. So we're really left with these three. We're no longer talking about FOBT or sigmoidoscopy, at least in our current setting, in the United States. And we're left, ironically, somewhat with the tests that have less evidence. And then there was this controversy around colonoscopy. So last month in the New England Journal of Medicine, this very direct title, Effect of Colonoscopy Screening on Risks of Colorectal Cancer and Related Deaths. This was a randomized trial. One arm got colonoscopy, one arm did not. And much of the media attention around this then became about colonoscopy efficacy. In other words, does colonoscopy work? And you might expect that this study with that title, that's what it was looking at. But we'll kind of take a little bit of a closer look. So this got a lot of attention. There were things on CNN, in NPR, and most of the major news outlets. It even became one of the topic stories in Saturday Night Live. What was going on with it? Well, really, the title probably should have said effective invitation to colonoscopy screening. So this was an effectiveness trial. It was looking at what happens in the real world if you start a program. And this was of high interest in the area where it was, which was in Nordic countries and in Poland and in Germany, because they did not have well-developed colon cancer screening programs. And they wanted to be able to see, well, what would it look like to be able to introduce a program of colonoscopy? So it had a couple of different parts. They identified a bunch of people, but even when you're looking at the flow diagram, it says assigned to colonoscopy or assigned to no screening. Really what happened was they were assigned to an invitation to colonoscopy. So this is different than the FLEX-SIG trials. This is different than the original FOBT trials, where there they said, would you like to participate in a study of screening? People said, yes, I would like to participate. And then they would say, okay, we're going to consent you. And now you're going to be randomized to getting this test or to not getting this test. So there always were some people then who wouldn't get the test, but they had consented even before. So this was a pragmatic study just of whether or not they were going to invite people. So you wouldn't necessarily know that from looking at the flow diagram. But what it came down to was that there are 42% of the people, which actually seems fairly high, accepted the invitation for colonoscopy. I've talked with the original biostatistician who designed the study, as well as the study's investigators, who I know from other settings, and it kind of be able to dig into some of the things that were not necessarily in the manuscript. And one of the things was, that this is not that far off from what they anticipated. They anticipated about a 50% response rate. So what happened? So as you might expect, there were some people who in this, there's 3 dot lines on this. The green one is participants. They were invited and they said, yes, we would like the colonoscopy, and they had it done. There were non-participants. They were assigned to the colonoscopy arm, but they did not get a colonoscopy. And then there are people who just did not get screening. So this is really an interesting graph because this is the cumulative incidence. And this is one of the very interesting things about colonoscopy, or really about colon cancer screening in general, because this has also been shown with FOBT. Colon polyps to colon cancer death is a very slow process. Unlike other unlike other cancer screening tests, where you're mainly about early detection. Can I find an early cancer that is curable? Colon cancer screening also has the opportunity for prevention because you can find these polyps and you can take them out. So this is all about that prevention part, the colon cancer incidence. Normally, if you're doing a breast cancer screening study, for example, you would always find a higher incidence in the screen group than in the unscreened group, because some of those would never go on to symptomatic cancer. So what you see here in that green line is, not surprisingly, when people start having the colonoscopies, the incidence goes up, you're detecting these, and then it gets extremely flat. And this is because, though, on average in that population, people are having colon polyps that are taken out, and so they're not getting colon cancer in the future. One nuance about this is if you look at the non-participants, the people who were invited to colonoscopy but didn't accept, seem to be somewhat lower risk than the average population of people who just were not screened at all. So if you assume that everything else was the same, then probably the participants who accepted were actually probably somewhat higher risk. So this may partly dilute what you're looking at. So overall, what they found with this and their intention to treat analysis was that there was about an 18% reduction in cancer incidence. There was a 0.9, a 10%, but not significant difference in mortality. And there was no difference in kind of the all cause. So this is kind of what made a lot of the news, was that even if you take large numbers of people, thousands of people, you follow them for 10 years, 40% of them get a colonoscopy, you're not affecting mortality. So that's a big question if you are a country which is putting in a program. I think the other part of it, though, is like if you are a person who's making a decision, which I think is where most people kind of put themselves, is saying, well, should I get colon cancer screening? Is there other information we might learn from with this? Well, one of the things that they did was they did a per protocol analysis. So they just said, well, let's assume that what would it look like if instead of 40% of the people, all 100% of the people had about the same amount of benefit? Well, the incidence rate was actually somewhat lower. It was about a 31% reduction in that per protocol analysis. The other twist to this, however, is that if you're looking at prevention, these ones that were detected early on, those were all cancers that were already there. So they had no opportunity for prevention. So theoretically, at some point, the first 1 year, the first 18 months, the first 2 years, you can pick some period of time, those cancers for both groups should not be included because there was no opportunity for prevention if you're interested in prevention. So probably, if you just look at this overall curve, even the incidence difference with that methodology, which is generally accepted to be an appropriate methodology, would be much larger even than the 31% reduction. The mortality pattern in the per protocol analysis was also different. There, it was about a 50% reduction. And that's closer to what we've seen. I'm not going to go through all the other studies, but we have done a case control study within Kaiser Permanente, which estimates what it would look like. And we're really probably talking about a 60 or 70% reduction in colon cancer mortality estimated from colonoscopy, which is huge. The benefit, as most of you all are familiar with, for things like breast cancer is probably in the 20s, even when done optimally. So something which is above 50% seems kind of really extraordinary. We'll take a look at some evidence to suggest whether or not that those estimates are probably real. So what are our conclusions about this particular study? Well, first of all, there was kind of moderate uptake. That's not that different than the United States. Even in colonoscopy-only programs, such as a large program which is in New York City, the rates are around 60%, and that's what kind of repeated reminders and in a much different environment that has very active information about colon cancer screening. The patients completing it were probably higher risk, so that probably somewhat underestimates the benefit. There were fairly modest population level benefits after 10 years. So if you were a country trying to decide where to invest your your efforts. There may be a fair amount of expense with this, with modest benefits at 10 years. The challenge is that the per protocol benefits seem much larger. The other part of it is that the incidence should probably exclude those prevalent cancers in years 1 to 2. And there are very long lag times for colorectal incidence and mortality because it is so slowly growing. The original statistician for this study, who created the original power calculations, actually stated that the original power calculations were for mortality estimates at 15 years. So it's probably just too early to be able to look at the mortality differences. And if you remember those curves, just like how flat they were, how much they're diverging, they're not kind of like bumping along together. The difference because of this slow long lag times is just going to continue to create a difference. They also didn't have a lot of information about surveillance and treatment in terms of what was happening. So hopefully this was helpful. If there are any particular questions around this, relating to I have the chat open, please feel free to be able to include those too. Were there any questions about this study or questions you've had from your patients? So one of them was, you report that the screened population was likely at higher risk. How do you measure risk? So this was actually the ultimate measure of risk was like how many people got cancer. So if you go back, let me see if I can kind of go back a couple of slides. Well, I'll just kind of leave it where it is. But what it was that the people who accepted a colonoscopy, we don't really know. When they accepted a colonoscopy, we found more cancers. The people who didn't accept a colonoscopy were at lower risk than the average population. So assuming that they did a good job with the randomization, if you take those people were lower risk than average, probably the people who had a colonoscopy were probably at higher risk. I hope that answers your question.
While we're at it, Doug, I'd love maybe explore that a little bit. You could wonder whether someone who accepts colonoscopy would also be someone who engages in healthier behaviors and therefore might be at lower risk. And you can also, thinking about what are the risk factors for colonoscopy that would make someone think they are or are not at higher risk. It's not like many other diseases where I think people understand the risk factors might be smoking or hypertension, and you have them, or what might cue someone in to say, I'm at higher risk and therefore I'm going to accept this procedure?
It's very complicated. Most of the time, in most studies, especially for a procedure, as opposed to the healthcare seeking behavior, it's oftentimes people who have, I'm having some symptoms anyway. I think I will participate in this study. We're actually doing a large study right now of trying to be able to identify people who have genetic history. And we thought, wow, everyone's going to want to be able to put in their family history with this risk calculator. They'll be able to be told what their cancer risk is and to have navigated care after it. Well, it turns out actually the people who are participating in the study are people who that are at about 4 times as many people who are at high risk participate in the study as people as is projected just in the general population. So it does also seem for that the people who are higher risk. So let's look a little bit then at maybe some of the progress parts. So that was one of the controversies. How does this kind of match with our experience? This was a study that we had published, and there's been a couple of others that came out close to this time period. But it said, what happens after you have a normal colonoscopy? So the one that goes across the top, that's the average unscreened population, matched for age and all sorts of other things. If you have a colonoscopy, your risk then of developing cancer, so this is not cancer death, but it's cancer, in the first year or two, gets pretty close to 0. It then kind of bounces along at about like an 80% lower risk than the average population, goes up to maybe 40 or about 60% lower. And that continues for greater than 12 years. Why does that make any sense? Well, it mainly makes sense because you're taking out polyps. So you're not only defining someone as lower risk because they don't have a cancer, but you're also then taking out polyps and other things that maintains them at a lower risk. The other thing, which is fairly compelling in terms of whether or not these work, this was a study that was published from our setting earlier this year in the New England Journal, where we looked at what happens when you increase screening. Now, KP has a remarkable effort around screening. It's led by T.R. Levin and a really broad team. I mean, it's people in the lab, it's people who are doing the colonoscopies, it's people who follow up on positive tests. And what was done in around 2006 was an effort to be able to increase screening from what had been kind of stable rates using mostly a sigmoidoscopy and FOBT program. You can see that's kind of the left side before that vertical gray line. And then in around 2007, there was this effort like, well, if we're going to really get high targets, we need to reach out to people, even people who are not coming in. And so it was decided that to look and see if they were up to date with colonoscopy or with sigmoidoscopy, and if they weren't, then to mail them a FIT test. So, within a few years, the proportion of people who are up to date with screening among both non-Hispanic whites, non-Hispanic blacks, we have more detail with full demographic breakdowns, very similar for all people of a variety of different demographic backgrounds. Almost all of them went up to around 80%. So this is this kind of combination of colonoscopy or FIT. Almost entirely went away from sigmoidoscopy to colonoscopy and went away from any FOBT to FIT. So then what happened with this big increase in screening? Well, if screening was ineffective, you would expect really kind of like nothing would happen. But what we saw instead were two things. So on the left is incidence. So, not surprisingly, again, the blue line is non-Hispanic whites, had been pretty flat, before this. It then went up, as you would expect, incidence would go up if you're doing more screening. But then the interesting thing, because colon cancer screening has this ability for prevention, is you started seeing this decline. There is also a large difference between non-Hispanic white people and non-Hispanic black people in about almost a 40 to 50% difference in incidence, as well as for mortality, which was on the right-hand side. What we then saw was that with this longer lag time, if you kind of like followed for about 10 to 12 years, there was about a 50% drop in mortality and about a 40% drop in incidence. And this is only with 80% of the population being up to date with screening. And this disparity between people who were non-Hispanic blacks and non-Hispanic whites diminished and essentially became eliminated, which was also quite remarkable, given this has persisted within the United States in general. So, that all overall supported the concept that a screening program works, although it is not randomized trial evidence. So the next question was, so there were a couple of questions I'll get to at the end, Alan and Dr. Burns, because I think that they may be kind of like relevant for kind of like pulling everything together. So the next question was like, which screening test is really best? So I think there's been the general feeling in the United States that there are two main tests that are used, although again, like the FIT DNA test the Cologuard test has become a strong, more commonly used third. So the randomized trials comparing colorectal cancer screening modalities, like none. So of the things that we're doing right now, we don't even have the direct comparisons with placebo. So there really are none. There are ones that are underway. They each have their own little quirks in terms of how interpretable the data would be. But currently, in terms of guiding us, we don't have that type of information. So much of what we have then comes from modeling studies. So let's look at what these show. So this was published in JAMA in 2021. And much of the information that I'm presenting is from the modeling group, which is used by the U.S. Preventive Services Task Force. And our group has been very fortunate to be able to have a number of collaborations with this group also. So I'm only going to show 3 of the tests, and I'm only going to show them in the way that they're recommended to be used. There's a few things that are along the bottom. This is the complications per 1,000 people at age 45 over their lifetimes in terms of likelihood of developing complications from screening. Those are mostly related to colonoscopy, bleeding, perforation, death. The next is colorectal cancers averted. The third is colorectal cancer deaths averted. And then the last one is colonoscopies. That gets a little bit beyond the complications into the concept of harms. So, colonoscopy is not a simple test. People have to take a day off. They have to take a bowel prep. They have to be sedated. Often someone else has to take a day off. And so there's really a lot that goes into doing one. And if you have lots of people doing it, a lot of like small to moderate harms, can add up to a fairly large burden at a societal level. So first of all, let's just kind of look at fit every 1 year. So, there's a bit of burden with that, because it is an annual test. The thought would per 1,000 people screened is you'd have about 12 complications. Again, those are really from the follow-up colonoscopies. About 50 cancers averted, about 26 deaths averted, and about 1,682 colonoscopies. So why is there more colonoscopies than there are people screened? That's because some people are going to be having polyps and they're going to be having follow-up colonoscopies. So you'll have some people who have multiple exams. How about colonoscopy every 10 years with any appropriate surveillance, if they have polyps found? So a higher number of complications, a higher number of cancers averted because colonoscopy is more sensitive to taking out polyps. About the same number of colorectal cancer deaths averted. So these were, by the modelers, these were stated to be equivalent, and a lot more colonoscopies. And then how about fit DNA? So if you remember, I said it was dominated. So it had slightly more complications, about the same, but numerically more than fit. It had numerically fewer cancers averted. It had numerically fewer colorectal cancer deaths, and it had about the same number of colonoscopies. And this is just because, although it has higher sensitivity as a single test, if you have with similar compliance, it has lower sensitivity if it's being done every 3 years compared with FIT annually. So this is a lot of interesting information. And it's one of the reasons why these have been felt to generally be fairly comparable to each other. Although there are these kind of subtle differences, the main difference, is the colonoscopy burden, and that colonoscopy probably is somewhat better at preventing cancers. So you're essentially having more polyps being taken out, but what FIT is doing is it is finding more of these interval cancers that might be coming up between the infrequent colonoscopy exams. So most people die from colorectal cancer from lack of screening up to date and not from ineffective screening. So this is an interesting concept that we had done an evaluation of 1,750 people within our system where we do screening and say, well, why are people dying? And it was to be able to get it like, well, where is the juice worth the squeeze? Where is most of the problem? Most of the people were not screened, or if they had been ever screened, they were not up to date. So this is not really about surveillance. Only 1% of those people who had died was actually not up to date with their surveillance. There were a moderate number of people who didn't follow up after a positive test, like they had had polyps that were removed. They should have had a follow-up colonoscopy because not everything was removed, or they had a positive FIT test that wasn't followed up on. But only 24% of the people died of colon cancer despite having had a negative test. If you contrast that with breast cancer screening and assume that you have about a 25% effectiveness and everyone is getting screened, that would be 75% of the people would be attributed to what might be called like test failure. So it really is about not getting screened when you're talking about where to put your efforts. So does surveillance matter? We put a lot of effort into surveillance. A lot of colonoscopies are done for surveillance. About half of the people who have a colonoscopy have one or more adenomas, precancerous polyps, and typically are recommended to come back early for surveillance. So does that make any difference? There's no randomized trials of it. And it's largely based on kind of like relative risk studies. So let's take a look at what surveillance might contribute if we're trying to be able to figure out where to put our efforts. So we looked at this before. This was the normal colonoscopy study. You have a negative colonoscopy, your risk is lower for a long, long time compared to people who are unscreened. This is what it looks like after a polyp is removed. So this again, was a study that we had done from our group that had kind of like looked at these different categories. So low risk adenomas, that's kind of like having 1 or 2 small adenomas. High risk is having 3 or more, or having a big one. On the bottom, the green line, that's that normal colonoscopy group. The blue line is someone who just had 1 or 2 small adenomas. Those lines are really about the same. So it's not because the low risk adenoma group was getting a lot more surveillance. And we actually looked at whether or not they were successfully following up with their surveillance exams. Most of them did not. So it really is probably about that. If you just have 1 or 2 small polyps and you take them out, your risk is about the same as if you had a normal colonoscopy, even though these people historically were coming back like every 3 years or every 5 years. So it's really this high risk group that seems to become a question. Now, I would say the high risk group is still lower risk than the average risk population, but maybe they're a group that might benefit from surveillance. So let's look at this even more. This is kind of those same numbers. The low risk adenoma group, not really any different. The high risk group, though, in terms of the hazard ratio, is higher. So, but let's kind of keep in mind that, double or triple a small number is still a small number. And so how does this kind of spell out in terms of kind of absolute risk? There's just to kind of toss this in there. There's a concept of serrated polyps, like a different type of polyp. It's flatter, harder to see, historically was not resected as well. And in general, people who have small serrated polyps, so this is no polyp, just one in the left-hand side of the colon or one on the right-hand side, a little bit higher risk for the right-hand side. But again, this is the absolute risk is different. It's mostly around the larger polyps. So this was a really interesting study also done by the Erasmus group, the U.S. Preventive Services Task Force group that was published a couple of years ago in the Annals of Internal Medicine. And what they said is like, well, we know a lot from working with a lot of different, population-based groups and from natural history data and from all these others, and kind of putting our data kind of like alongside what happens in the real world. Let's see what happens if we just said, ignore what we found on your colonoscopy. Let's just put in different scenarios, such as we are never going to do another exam on you again. That's the top one. Or we're just going to assume that you didn't have anything and we're going to just rescreen you in 10 years, the way we would an average risk person. And then they also did a low intensity surveillance and a high intensity surveillance. So now those low intensity surveillance and the high intensity surveillance, the high intensity one is actually what has traditionally been recommended for most people. So repeating an exam in 5 years, for example, for a low risk adenoma, and 3 years for a high risk adenoma. So that's the one that you kind of just think of as, in general, has been the standard of care. So look at what happens down here. So you start off at age 50 and you're diagnosed with a polyp, and then you're just kind of followed and followed and followed and followed and followed. When do these curves diverge? They don't diverge for about 20 years. So even the top one, which is nothing, you don't have another exam at all. That doesn't really start to diverge from what might be even considered the return to screening every 10 years, that kind of like dashed line, until about 20 years later. So this would suggest that even whether you're having low risk surveillance or high risk surveillance for a low risk adenoma, that it's not going to make much of a difference. And actually our surveillance intervals may be even too aggressive every 10 years. Now, how about high risk adenomas? So this is even for the high risk adenoma. So this is where that relative versus absolute risk thing comes in. So again, really the curves don't substantially start to diverge until you are about 20 years out. So that's a return to screening every 10 years is also very similar. That's this kind of red line, the second one, to kind of like the low and the more intensive surveillance one. So realistically, we're probably doing too much surveillance. And to address this, one particular group said, well, maybe we should really be kind of reclassifying patients. And so without getting this into too much detail, they kind of said, look, if you have 1 to 2 small adenomas, that should maybe be like 7 to 10 years. And other people should be getting it like more frequently, but that's not just like 3 or 4 adenomas. There should probably be people who have, like 5 or 10. So 1 year would be a lot of adenomas. 3 years would be kind of like 5 or 10, and everyone else would be more or less treated as average risk. So this definition of high risk, the kind of like they looked at a whole bunch of people who had high risk as greater than or more than or equal to 3 small adenomas, or they were villous, or they were big. And so this is one of the questions that Dr. Burns is raising out. Does histology define high or low risk, such as adenoma or villo-glandular versus serrated? Serrated, not so much, but villous does, and high-grade dysplasia does. So the challenge was that because we're detecting more and more of small adenomas, 35% of all of the patients, 35% of all of the patients with adenomas were high risk based on the current definitions, and that was mostly around having 3 or more. So they decided to look at this in a different way and said, well, let's just look at it rather than if you have 3 or more, let's just look at them if they're really big, or if you have high-grade dysplasia. And then they said, what is the risk? And so the new high risk, that's the one on the right, it's higher risk than before. The risk among those that were moved into, say, let's just say they had 3 or 4, those then are about the same as the current low risk. The difference is that now only about 9.5% of people are considered high risk. So this is we're probably going to be moving towards this. You're probably in your practices going to be seeing more, and probably already are, that the guidelines are going to be changing. There's going to be less surveillance and an increased appropriate emphasis on getting people in for screening. So redefining high risk would reduce the high risk group by about 74%. So essentially, you're taking people who have only risk, really no benefit from colonoscopy beyond the average risk group. So essentially, they are being harmed by having more frequent surveillance, and then you're identifying the group that actually really is at greatest risk and should be getting the most intensive surveillance to be able to focus on being able to get them in. So you may reduce the burden and harms while preserving or maybe even increasing benefit if you're really looking at and focusing on getting the high risk group. So let's go on to the last part. And this is an intriguing one. Does it matter who does my colonoscopy? I'm just going to start off by saying, this is very similar to probably everything that we do in medicine, if you were to take a close look at it, or really everything we do in life. How completely does someone come to a stop at a stop sign? How thoroughly does somebody brush their teeth? And then the question kind of gets to all right, and do those differences make any difference in outcomes? So let's take a look at this. Many of these questions that we've been talking about today, including the ones we're about to talk about, were evaluated within the National Cancer Institute's PROSPR consortium. This is really a screening consortium that looks at colorectal cancer, lung, and cervical cancer. And the main sites for which we help to be able to coordinate are the colon cancer sites. And that's at KP Washington, Northern and Southern California, and the Parkland Health System, which is largely a safety net system. So a number of years ago, we had published an article around this topic that had showed associations between what's called adenoma detection rate. That means if a physician does 100 exams, 100 different people, what proportion of those exams do they detect at least one adenoma? And historically, this varied about tenfold between physicians, and most of the adenoma detection rates were in the teens, 20s, and 30s. So the adenoma detection rates have gone up. So we kind of updated this, and this was published earlier this year in JAMA, just saying, look on the bottom, it says time after colonoscopy. On the y-axis is your post-colonoscopy colorectal cancer rate over time. So if your physician has an adenoma detection rate of less than 20%, that's the gray line. 20 to 25-ish is that kind of bluish green line, et cetera, et cetera. So you can see that it actually is quite a big drop off. And if you are in this group, more or less when you start getting into the 35 to 40 and up, your risk of having a post-colonoscopy colorectal cancer is about 50% lower than if your physician was in this group up here. Your risks of death from colorectal cancer are also about 50% lower. So this really gets to the effectiveness or even the efficacy of the exam because it actually can prevent cancers as well as detect them. It seems that taking a close look and removing polyps does make a difference. We had worked with the modeling group before to be able to look beyond just like a half a dozen years, like what it looks like over a lifetime. And the reductions are even greater, kind of like as you move up these, quintiles of adenoma detection rate, that the preventative benefit, can between the lowest and the highest groups are really quite substantial. And, and interestingly, not surprisingly, this, because you're having the exam anyway, and it doesn't really cost that much or really anything, just a little bit of extra time. There's almost no cost to this intervention of having higher adenoma detection rates, but a marked reduction in cancer treatment costs and the net screening costs. There's a little bit increase in screening costs because you're finding somewhat more polyps, and so there's some follow-up colonoscopies, more surveillance, but the net screening costs go down. So this is really one of those win-win-wins, more higher value care, better patient outcomes. Now, sometimes people will just say, "Oh, we'll just look longer." But actually, I'm not a big advocate of measuring withdrawal times or how long you're looking, because all of the studies have shown that really careful inspection leads to longer exam times, which leads to greater adenoma detection. And interventions that have just tried to be able to say, our intervention is having people look longer and make sure that they look for at least this amount of time, does not lead to more careful inspection and has not led to higher adenoma detection rates itself. Some devices can help. There's a lot of industry around this, but without going into that in a great detail, the main thing is probably developing a quality environment, having good bowel preps for everyone. And then I'm going to show one thing on something else that we have, which is kind of under review currently, but a different type of training. So this is what our adenoma detection rates, the 0 point on this, and then -3 years and +3 years. Each of these numbers, like 12, that's 12 quarters. So if you kind of we've looked at the time period kind of going back and forth between 3 years, there's a little bit more data than that on here. But you can see that the average adenoma detection rates, the top half are people who are in the top half of adenoma detection, and the bottom half is the people who are in the bottom half. But our average adenoma detection rates in both of these groups actually went up by about 15%. So every 1% increase equals a 4 to 5% reduction in cancer incidence and mortality post-colonoscopy. So a 10% increase is actually about a 50% reduction in colon cancer deaths. And so with kind of this combination of training and feedback, and with the training, just the training, which was just like a 30-minute intervention, it went up by about 5% in the people who are below the midline, which is a 25% reduction in cancer incidence. And we had looked not only whether ADRs went up, but also whether cancer incidence went down, which is kind of like a separate analysis. So, overall, this has increased a lot over the last decade in different settings. This kind of prompt increase for lower detectors, markedly decreased variation, kind of very high value, even like 100 fewer cancers over a few years, would be greater than $10 million, kind of like to the healthcare systems. And yet, most healthcare systems and settings have not really invested in these quality efforts because there's not kind of like a direct fee for service reimbursement for it. And it kind of like allows this next step studies. So, and that there are existing quality guidelines around this. So, this is kind of like what that particular intervention is, and it kind of had been used, some best practices that had been developed over time. For those of you who don't do colonoscopy, this is why adenomas are hard to be able to detect. If you look at the top right, that's a polyp. It's in the middle. It's the place where the blood vessels are not going through. On the top left, that's kind of a little harder to see, but it's a big flat polyp. It actually covers most of the screen. And as you can see there, you can't really see blood vessels, but it just kind of looks pink. On the bottom left, there's a little polyp, which is kind of, I'm kind of circling here, just that kind of like a little bump. And on the bottom right, what looks like two folds, actually the fold that's closer to you is a polyp, which is wrapped around a fold, but a very flat one, just with a very slight difference in texture. So these actually are hard to be able to detect, and that's what these trainings are about. So In general, improving quality is about, being able to have good preps. Some devices can help, training programs, pathologist training actually to be able to make sure that you're identifying adenomas correctly has been chosen to make a difference. And these kind of MD level interventions, it should be straightforward to replicate and disseminate. We have this training is actually online through KP, and it's available to anyone who is interested in different settings, and is currently being used in some fellowship and other training programs or within quality programs. So in conclusion, does screening work? Yes, likely our current tests are effective, and they have been suggested in when used at high levels to be able to also close disparities. What screening test is best? It's generally said that the one that gets done. And offering multiple leads to more screening rates. So I don't think it's so much about anchoring your star, hooking your screening star on one particular test, but probably offering a couple of different ones. That seems to substantially boost screening. Most people who die are people who are unscreened, not people who are not in surveillance. It's really about or which test they get. Does surveillance matter? Likely modest benefits over 10 years. Again, it gets to this focus on getting people screened. We'd do much better probably to get in whatever setting we're at, the 20, 30, 40% of people who are unscreened screened than to really be kind of like hammering on getting someone who has small adenomas, back for surveillance. Does it matter who does my colonoscopy? Yes. This is actually a fairly substantial impact on post-colonoscopy cancers, which comprise a moderate amount. It's about 1 out of every 20 cancers is one which is identified. 1 out of 10 to 1 out of 20, depending upon your setting, is a post-colonoscopy cancer within 3 years of the colonoscopy. So a fair number of cancers happening in fairly short order after negative colonoscopies. So quality really equals effectiveness. On behalf of our teams, it really takes a village. Thanks so much to the National Cancer Institute, to our colleagues at Erasmus, my colleagues really kind of in all of these different settings, and look forward to your questions. And we'll try to be able to get to some of these then that are in the chat. Thank you so much.
Great, Doug. Thank you. That was terrific and really interesting. It's a really interesting field. Let's start with a question from Alan Minook. So one of the hot issues you didn't get to was this new recommendation about starting screening earlier at age 45. What's the evidence base behind that? Does it make sense to start it earlier, or is that in some ways overscreening?
So just to recapitulate, the previous screening age that was recommended was age 50. There were some populations that were higher risk that were recommended to have it at an earlier age. There was a lot of discussion because there was increasing cancer incidence among people less than 50. Now, the reality of what a lot of this really turns around is, again, if you double a small number, it can be doubled, but it's still a small number. The number of people who get cancer who are between 45 and 50, that increase in incidence was, in absolute terms, was very small. It's a fraction of like the difference between 60 and 65. For example, cancer incidence goes up so much with age. So one of the modelers actually had done a study saying, well, hey, if we screen all of these people between 45 and 50 versus just like a moderate number more who are like have not been screened, and who are in their 60s, you'd be way better off putting all of your resources into that other group. With that being said, with conventional cost effectiveness measures, it was considered to be cost effective at current incidence rates. And this is mainly because colonoscopy in most settings is not just cost effective, it's often cost saving because you're preventing cancers, and also those younger patients had so many life years in front of them that the benefit is higher. And I know when I talk to our oncology fellows, colleagues, it's just so heartbreaking, when they're, even though it's a small number, seeing the increased number of, people who are in their, 40s getting colon cancer when it seems so preventable. So I think it's a reasonable recommendation to be able to increase for the change to 45. It raises all sorts of questions on like, how should you be screening that population, using the most intense methods or whatever. And that's, depends a little bit on your setting. But Alan, I hope that answers your question regarding that. and I would be cautious to be able to say that there's a near epidemic of colorectal cancer in people between the age of 35 to 45. I do think what you see depends upon where you stand. And within oncology, seeing some people in that age is very different than there being an epidemic. The absolute risk is extremely small among people who are below the age of 45, where there would be probably way more harms that would be introduced by trying to be able to screen everyone in those ages. We do this for everything, right? We don't do mammography among people who are 30 years old, even though there are people who develop breast cancer at age 30. So it's a very similar concept.
If you've convinced us that the adenoma detection rate is important, how can someone find out what it is before they make a decision about who's going to do their colonoscopy?
That's a great question. Not very few places kind of like publicize this, although a few do. Fortunately, over the last several years, most places have started to be able to calculate it. Some of those calculations can actually be a little gamed because it's been based on screening exams, and sometimes the screening exams, whether an exam is screening or not, is actually determined by the gastroenterologist after the exam is over. We're about to publish actually some information that you don't have to do it just on screening exams. You can just do it on total exams. And so I think that'll probably create an easier to calculate standard. But kind of pulling two things together is you can ask your gastroenterologist whether or not their group calculates it or not, and what theirs is. It may be a little uncomfortable, but you can. It's something you can actually ask them, and I think a lot of people actually know what theirs are. There was a question from Dr. Jones about like what ADR would you want your doctor to have at a minimum? Currently it's 25%. I would say, I would probably want someone at a minimum to have it greater than 30. Most people now, like in our setting, are greater than 40. So, you start having a diminishing returns, probably at the higher levels, but definitely I would say greater than 30. And I think the guidelines are probably going to change to that.
And Doug, it seems like the protocol typically is whatever screening method you were using, once polyps are detected, and if someone recommends in a shorter interval, the next test is a colonoscopy for that shorter interval. Given the relatively low risk and the time lag of at least the low risk polyps, does it have to be a colonoscopy that you get followed up with, or could it be another non-invasive test?
That's a great question. I'm not sure if my colleague TR is on the phone, but essentially there was a large pragmatic trial by P. Corley that's just launching to ask that question. Hey, does it have to be another colonoscopy, or maybe for these low risk people, the stool test for people who don't want to have another colonoscopy would be better, as good as, and certainly and possibly better than not having anything at all.
Mm-hmm. And the data, you made the point that the fancier fit DNA combo is no better, and yet it's being marketed like hell. Is there any rationale for that test, or you think that the evidence would say that you're just fine choosing between a fit test and a colonoscopy?
It's such a personal choice in some ways. What it comes down to is like the modeling studies can show one thing, but then you have to decide what you're going to do. And if you're like, oh yeah, no problem, I can do a fit test every year. If you're like, I'm just not going to do that, but I could do something maybe once every 3 years, then that would be a better choice, because that would probably have higher performance. I think the thing which gets very confusing is about test performance, single test, versus like, if I use this over 10 or 15 or 20 years. And that's where they become very equivalent. But as a single test, what the hype has been around it is that it has greater sensitivity. That's true. Colonoscopy also has greater sensitivity than a fit test, but these other tests also pick things up, in the interval between colonoscopies. So one of the things people have said is like, well, then why not get a colonoscopy and then do a fit every year? And then you'll have the best of all possible worlds. And that is an option. Again, it just has never really been studied, including what the potential, kind of like implications. And I think the main thing right now has just been trying to be able to get people screened, with one versus the other, as opposed to kind of making it even more complicated.
Yeah. Maybe last question. Thanks. You mentioned that the best, other than maybe the serratedness and maybe a couple of pathological characteristics, but in some ways the branch point for how serious to take your polyps and therefore maybe guide your screening, is how many you had. Is that just probabilistic? If you've got 10, there's more of a chance that one will become cancerous than if you have 2? Or is there something different about the colonic milieu for someone who has 10 than 2?
It's probably probabilistic, but for the second reason that you said. Because the polyps are taken out. So if you have 10, theoretically, those 10 were taken out and they shouldn't cause you a problem in the future. But it's probably probabilistic on the other part. Like if you got 10, you're probably more likely to get more in the future than somebody who, didn't have any at all.
Got it. Yeah, great. I think we're at the hour. We can go on forever. This is really interesting, and it's wonderful to have you. You've done such pioneering work in this along with your colleagues. Thank you for joining us, and thank you for being at least part of your life in our world. Really appreciate it, and keep up the great work. And so let's go ahead and sign off. Thank you, everybody, for joining us today. We'll be posted on YouTube in a couple of days, I think. Stay well. We'll see you back here next week.